Professor Helen may not be able to join us. Okay, we will still have a discussion with the questions that have been sent earlier, inshallah. Let's see, 2019. Okay. All right. Let's start. Bismillah, alhamdulillah. Wassalatu wassalamu ala rasulillah wa ba'd. Assalamu alaikum to those who watching live with us today. Alhamdulillah, we have Dr. Gray with us. He's my lecturer. He used to teach me at medical school. So welcome, Dr. Gray.
My pleasure.
Good. And I think, unfortunately, Professor Helen could not join us today. But we will still have a good discussion about the vaccine and all that. Dr. Gray will cover some of the questions. And Dr. Gray, just before we start, how's retirement life for you at the moment?
Oh, it's great. I'm only half retired. I'm working hard at the university, writing papers and of course, preparing for next year and the students arriving.
Oh, good. So the university will get any international student this year?
Well, no. Except for those who are already here.
Oh, right. Okay. That's good. Okay. Now, so just a little great. Just to those who don't know you yet, can you just please introduce a little bit about yourself, and then we'll start, inshallah.
Sure. So I'm an associate professor at the University of Otago, Wellington. I've worked in general practice for all of my practicing career. My last 27 years was at Newtown Union Health Service, which is high needs in a city practice, which caters for a lot of people from all over the world, particularly refugees from all the refugee groups that have come to New Zealand. So, and my particular research interests have been around working with interpreters and cross-cultural care. And I've been particularly interested in ethics and how that applies across cultures and a variety of other things, because as a GP, I'm a generalist. So I dip my finger in all sorts of issues.
Good. Oh, I'm sorry, I didn't realize that now you are associate professor as well.
Yeah, my new promotion.
Oh, okay. Well, look, I'm very pleased to have you today, Dr. Gray. So let's start. So I think this topic about a vaccine is quite important, right?
Yeah.
And we in New Zealand, I think I'll start a little bit from me as a Muslim perspective, as a Muslim, okay? For us as a Muslim, it's very, very important. Allah says in the Quran, فَاسْأَلُوا أَهْلَ الذِّكْرِ إِن كُنْتُمْ لَا تَعْلَمُونَ. Then ask those who have knowledge, So if you don't have the knowledge, you ask someone who have the knowledge. So, and that's why we wanted to do this program. We wanted to discuss about these things. And then we want someone like Dr. Gray to discuss about this issue. Now, one of the major things, Dr. Gray, as you know, with the social media and all that, there's so many disinformation and misinformation out there. And there are many things and many claims about vaccine, and people worried about vaccine. And that's fair enough. And I think for us in New Zealand, for me in New Zealand, I'm speaking about from my perspective here. In the UK, in the US, there's so many distrust about the decision that being made by the government and all that. For me in New Zealand, I think I trust the system here. And I think I'm quite happy the fact that in New Zealand, we're not, the vaccine will be brought in. At the same time, we will also be doing our own tests. We will going to be looking at the MedSafe, and I think another organization will be looking into it, IMEC and all that. They will look into the studies and research, and then they will approve when they're happy with the whole procedures and the one that they put everything in place. What's from your perspective, Dr. Gray?
Yeah, so I think there are a number of things here. The first is that I think there's been a lot of people talking about the urgency that we should get the vaccine quickly, when in fact we are going to be very lucky not to be the first cab off the rank, because other countries who have a much more urgent need to be vaccinating. So if you've got a raging epidemic, you want to be able to vaccinate your vulnerable populations as soon as you possibly can, because if you don't, many of them may die. Whereas in the New Zealand setting, as long as we are able to keep our borders well controlled, we don't have that same urgent need to protect our vulnerable population, because we're protecting them by keeping the vaccine out. What that means is that we don't have to urgently approve something before all of the data and studies have come in. And so one of the benefits of this will be that we will benefit from all of the experience of all the other countries who are starting to use the vaccines. The other really important thing here is that there are different vaccines and they work differently and they have different effects. And we need to choose which are the most effective one for the New Zealand setting. Now, again, the issue, I mean, I understand, for example, that the Chinese vaccine has been used in Brazil, but they found that in Brazil it's only about 55% effective. Now, in the middle of a raging epidemic, 55% is, an awful lot better than nothing. Whereas if we're using it to try and prevent incursion at the border, we don't want to immunize our border staff and only have a 55% effectiveness rate, because that still means stuff will get through the border potentially.
Yes.
So one of the benefits of waiting will be that we'll be able to get not only, and this is the important point, that initially all you get is the research data. So the data from the trials where they've got, guinea pigs, and they've got two groups, one group who have the vaccine and one group who doesn't, and they measure them and see what the side effects and so on is, and then they release it. But after that, you get real-time, real-life data. So all of the countries that are vaccinating are keeping records of how many people have side effects. They're looking at whether they're immune and whether they get the get infected after having had the vaccine. So there's a whole load more information coming in all the time. So that's I think one of the big benefits of us not needing to jump very quickly. It'll mean that we'll know about the ones that we're considering and can make a good decision about it.
Good.
I think the other point that's probably worth expanding on is what you were saying about the institutions and whether we trust them or not. Yeah. And I think we're really fortunate in New Zealand that to date the government has done a good job of listening to the science, of making judgments, of caring for all of us in a way that clearly America and Britain have not done so well, and they're in the middle of an uncontrolled epidemic in both places. Yep. And one of the problems that then leads to is that if people don't trust the government, then if the government says the vaccine is safe, a whole load of people will say, well, I don't know. And a really good example is that in the USA, in America, the Federal Drug Administration Agency, which is the agency responsible for approving or not a drug or a vaccine, they approved hydroxychloroquine as a treatment for COVID rapidly because there was one study from France on 20 people and were pressured by the president. And it's subsequently been shown to be completely ineffective. Right. And so people will have lost some trust in the FDA to make good judgments, that they shouldn't have responded to the pressure from the president. They should have said, no, we're not going to decide on this until we have good enough data. So that's one of the things which people may want MedSafe to work more quickly. I don't. I'm really happy that MedSafe will take the time that they need to make a good decision. And at the end of that process, I'll be very happy to take their advice.
Good. Yeah, I think we both agree on that. I think that the fact that the government take its time, it's actually a good thing for us rather than rushing it, because as we all know, our borders are well controlled. Yes, we got one case recently this week, but other than that, we're pretty much in a good space. Yep. Now, let's go to so a couple of the viewers already sent me an email and sent me a text messages about many questions. Yep. So I select a few questions. Good. Now, the most important question, Dr. Gray, what do you think about the people are asking us, can this vaccine will give us a permanent immunity?
Okay, I mean, it's a really good question. And the answer to that is we don't know. Because if you think about doing the science, the only way we can know whether any particular vaccine will give long-term immunity is by studying all the people who've been vaccinated for a long time and seeing whether any of them lost their immunity. Now, that's the only way we can be certain. Now, we can know more about some of the vaccines because some of the vaccines are modeled, are essentially very, very similar to other
Yes.
vaccines that we use. So, for example, the hepatitis B vaccine, we know that if we give 3 doses to someone and they respond at that time, they will be immune. Whereas even though we may not be able to measure their immunity at a later time because it's not measurable, we know that they are immune from all the studies we've done. So it seems likely that for some of these vaccines, that may well be the case, but we can't be certain about that at this stage. There's some uncertainty in there.
Okay. So that's actually, I think we'll follow through with the second question that I've got about why do we need 2 doses of vaccine? Right, and then I think you answered it nicely. You give an example about hepatitis B vaccine that we use in and that we need 3 doses.
Yep.
So if you just explain it to our viewers a little bit more, why 2 doses of vaccine?
Okay, and I think the simplest answer is because that's what works. And so the thing is that in terms of the studies using these vaccines, they work out what is the thing which will give sufficient immunity. And the reason for more than one vaccine, in some cases, it's because 1 dose of vaccine may only mean that 70% of the population will become immune. When you give the second dose, it goes up to 98%. So it's possible that some people might be immune with 1 dose, but we don't know which ones they are. Whereas if we give 2 doses, we know from the studies that after 2 doses, a very large proportion are immune, or after 3 doses, as with the hepatitis B vaccine. And then there are other vaccines that we use where we only use a single dose. So the flu vaccine, for example, each year we only give 1 dose of flu vaccine.
Yes. I think for New Zealand, we have a few vaccines that it's coming. Correct me if I'm wrong. Pfizer and BioNTech. I think that's the first one is about to be, and that require 2 doses of vaccine.
Yep.
I think Novavax also require 2 doses of vaccine. And I think AstraZeneca also require 2 doses of vaccine. I think except for, is it Janssen Pharmaceutica? I think that's most likely need a single dose, as I understand it.
Yeah,
so,
I'm not aware of all the detail of those, but I think that that's exactly the sort of thing which I expect MedSafe to be the people to go through the literature and to determine how certain it is and to advise us on what we do with that.
Good. I think before we go to let's just go one more question here and see what do you think. So I think the most important thing, the majority of the time, as a GP, as a doctor, the most thing that the patient tend to ask about is side effects, right? And I think that's something that we have to acknowledge here, that we have to discuss this. So what do you think? I mean, we know a little bit about side effects, but every now and then, you open up a CNN or any other news channel. Oh, I've got a vaccine, now I can't walk. Now, this so-and-so have a vaccine and they die from the vaccine. So I think we have to discuss this thing. I think this should be discussed up front. And what do you think about that, Dr. Gray?
Okay, so again, if you think about how do we find out whether a vaccine has side effects, and the way that we do this scientifically is by doing a study where we have a large number of people who have the vaccine and another group of people who have a placebo, in other words, an injection which has nothing in it. And then we look at the 2 groups and we compare how they fare. And the thing is, if you follow any person for a period of 3 months, 6 months, many of them will get will get symptoms. They'll get a sore back, or they'll get a headache, or they'll get a rash, or they'll get something happening to them. And so the way we try to sort this out is by having the placebo arm, the people who didn't have the vaccine. And if we find that the number of people who get headaches in the group that had the vaccine is, say, 10%, and the number of people in the placebo arm who get headaches is 10% as well, then we can be reasonably sure that it's not a consequence of the vaccine. There will be other side effects, and particularly one of the things that is the worst possible thing from a vaccine is that some people will have an anaphylactic reaction, an acute allergic reaction. And the more immediately after the vaccination happens, the more sure you can be it was because of the vaccine. And that is one of the things I understand about the Pfizer vaccine, is that the incidence of allergic reactions does seem to be higher, significantly higher than for example, the flu vaccine. So some of the side effects are things which we can more easily attribute to the vaccine. And if you did the comparison between the placebo arm and the vaccine arm, the placebo arm, hardly anyone will be getting an allergic reaction. So that's the way we have to do it. And then the problem with this is that we give this to everyone, whether they have symptoms or not. And we were talking earlier about they have vaccinated a large number of the elderly population in Norway, and it's been reported that a number of people have died. And if you took a large population of elderly people and then followed them for the following week, a number of them would die. Yeah. So it's quite difficult to be able to say that person died because of the vaccine. So it's a difficult thing. So we can't reassure people and say there are either no side effects or definitely these side effects. We can only say, well, our best understanding is this. And the other thing about that is the more we've used the vaccine, the more we know about it. So that's why New Zealand doing it later than the rest of the world, there'll be more and more reports coming out from people receiving the vaccine reporting these sorts of side effects.
Yep. Good. All right. I think that's great. Dr. Gray, are you all right there? I think you're a bit,
yep.
I think your internet a little bit. Okay, that's fine then. Good. Just one more last question. One of the other question here is, which I think we pretty much kind of sort of covered it. And a lot of people are wanting to know why or how can we be certain about that the vaccine will protect us from the different strains.
Yep.
And I think this is another problem, because like you say, you mentioned about politicians before, we talk about hydroxychloroquine just now. And in the UK, the Prime Minister there said, I think he said it's not covered, and I think the discussion about it's covered. So and when for us general public, when we read that, we were like, so which one? When are you covered? Are you not covered? I think, and some people are just saying it without actually understanding how we need to look into that. So if you just explain that to the viewers, please.
Okay, so I think the issue here is that any infectious disease will mutate over time. So it's normal. This is not at all surprising that there are different variants around. And the different variants will respond differently, because this is natural selection. This is why all of the animals on this planet have varied according to their environment to be able to survive longer, and the vaccine and the virus is no different. So that's going to happen. The second thing about the variants is that we find out about them if people do a lot of genome sequencing. So we know exactly what variant we're dealing with. Now, in New Zealand, we're genome sequencing every single case of COVID we get. It's not very many. It's not very hard to do that number. And the reason we do that is we can then find out, for example, that the latest community case was caught from someone within managed isolation, because it's exactly the same variant.
Correct, yes.
So we are genome sequencing all of them. Now, in Britain, I understand they're genome sequencing somewhere around 10% of their infections. Now, that's an awful lot, but it's still only 10%. And in America, they're hardly genome sequencing any. So the thing is that we found these variants, and there are a whole lot of other countries that will also probably have variants as well. It's just they haven't been measuring them. So in a sense, there's not much point getting too worried about it. The main point is to continue evaluating the vaccines that we're using and seeing whether they work and what difference the variations make. And, we may need to do something at a later time. You may be aware, I'm sure most people are, that we have a flu vaccine every year.
Yes.
Because the influenza virus varies and changes each year. And it's possible that we could end up needing to get a COVID virus vaccine every year, because it keeps on circulating and it changes over time. That's a possibility.
Yes,
we don't know
true.
that we'll get there, but it's a possibility. So I think the thing about the variants is something that it's not at all surprising that it's happened. It's probably more extensive than we know. All we know is from the measurement that's been done, and most countries aren't doing that degree of measuring. And the only way we can find information about that is really just by monitoring the vaccination we're doing to the people who've got the variants, to then study how well the vaccination works in that group, because the original study of the vaccine was done on people with a slightly different variant.
Good. All right. I think those are the main questions that I've received prior to the our show, and I think those are the main one that people tend to ask you about. Why 2 doses?
Yep.
To those who just joined in, you can listen to this. Listen after the podcast today. You can go back and listen to it. So we cover about why 2 doses, why the need for 2 doses of vaccine. We cover about whether this will give you a permanent immunity, and we also give you a good discussion about side effects. So I think, which is quite important, right?
Good.
So I think we've got a few comments here, as you can see.
Well, I'm happy to start working down some of those if you like.
Yeah. Well, let's start with which one do you want to start? Do you want to start with?
Oh, I mean, I could talk about pharmaceutical companies easily.
Yep.
In that they're from all over the place.
Correct.
So Russia has produced one, China has produced one, India has produced one. We know that the one from Oxford that's the AstraZeneca one. Pfizer is a US company. So, I mean, they're from all over the place. I don't know explicitly whether any of them are from Israel, but I think that they will all come from different places.
Correct. Yes. I think China brand is Sinopharm, I believe. I think
right.
You've been used in Africa and all that. Yeah. Okay. Now.
Okay. The question of mistrust, I think, is a really useful one to talk about.
Correct. Yes.
And I think that there's a number of elements to that. I think the first is that science claims to do things well, but we are far from perfect. And so one of the things which happened to significantly impact on the trust in vaccines was the paper published by Andrew Wakefield, where he suggested that the MMR vaccine was associated with the development of autism. He has subsequently been struck off as a doctor. His paper has been completely repudiated. It was fraudulent. He had a company that stood to benefit from that finding. And they've done multiple studies and shown that by doing other studies after his study, that there is no association between autism and vaccination. But if we published an article like that, which wasn't true, in a reputable medical journal, how can we be sure that all the other articles that we say are true are correct? And I think that that's just one of the problems that science has, which is that we're only as good as all the people who are doing it. And like the rest of the world, there's some bad apples in amongst us. However, one thing I would say about vaccination is that unlike much other pharmaceutical research, it's often research done on people who are very well. And so you're much more likely to find the benefit and harm than if you are, for example, doing a trial looking at treatments for someone who's very sick with a cancer. They're already unwell, so if they get nasty side effects, they may not notice it. So I think the science around vaccination is a whole lot better than other aren't. But if people don't trust it, then it's just a matter of talking with them and saying, okay, what do you want to do about that? And the way I usually approach it is by saying, okay, I mean, as a doctor, I have experience. Well, I actually haven't seen anyone dying of tetanus, but I know about tetanus. And if you have a vaccination against tetanus and you get it, you don't die. And if you have if you don't have the vaccination, then there's the risk of you dying. That is true. And so, you need to think about, okay, what are my risks? And in a New Zealand setting, the issues around measles are probably the one that are most interesting, because some years back, we didn't have any circulation of the measles vaccine. And so if people didn't get the vaccination done, there was no harm to them because there was none communicating in the community. But the measles is a very, very infectious disease. And so if it starts communicating, it communicates rapidly, and people will have heard of the idea of herd immunity. To stop a measles epidemic, you need to have a very high herd immunity, because the virus will find out the few people left who haven't been immunized.
Yeah.
And so that's been a thing where that's the way that it tends to work with. And it's really just explaining, listening to them, understanding what their concerns are, talking with them. And the way I think about it as a GP is you need to develop a relationship where they trust you. And it may be a matter of they'll trust me to let me give them the tetanus vaccine, but they're not quite ready to try the MMR or whatever. And you just keep on talking and being open to discussing them and respecting their position, because they have a position that needs to be respected.
Yes. Now, I think that's a very, very, very good point as a GP. You mentioned about, you've been a doctor for, I don't know how many years. We wouldn't
Couple of weeks.
40 years, 50
Yeah.
years. Now, you talk about, so as a general practitioner, and vaccine has always been given at the general practice, right? So in your practice, have you seen any of your patients that has the vaccine at a young age, or, for MMR and all that? Let's just talk about vaccine in general. Have you actually seen anyone with a major side effects in your experience? Yeah.
No, in fact, I've seen more from patients who have had illnesses which could have been prevented by a vaccine.
Okay. And I think people also forget about, you mentioned about measles outbreak, and I think the first thing that came to my mind was Samoa. The 2 years ago, yeah?
Yeah, that's right.
And it was devastating to see how many children died from measles.
That's right.
And some of the description, where the children just basically piled up and been buried in one weekend.
That's right.
that was horrible, and the hospital was full, and it's easy to forget about those things, right?
And I think one of the issues around people being reluctant about vaccination is that they usually haven't had any experience of the illness that we're preventing against.
Correct.
And so one of the things that I'm hopeful in relation to COVID is that actually actually in New Zealand, not many will have had experience of it, but there'll be an awful lot of New Zealanders who have friends and family overseas who have had experience. And so I'm hopeful that will work. Just Sharifa made the comment about what we do about getting around language barriers.
Yes.
That's one of my particular pet topics. We use an interpreter. It's really, really important that we work around those language barriers. And we now have 24/7 interpreters available, mostly on telephone is easiest, or video interpreters. There's also an important role for bilingual clinicians, and I'm not sure how good your other languages are, Firdaus, but mostly, I mean, I know within Wellington, all of the Assyrian patients, for example, know that there's one of the chemists in town that has an Assyrian person working there. So making sure that those who have language of their particular community are able to use that benefit, because it's much easier, obviously, if you can discuss this in your own language. But it's a really important point to work out how to deal with that, because if you can't talk, it's not going to work.
And I think there's one more point there that I like to say, as a GP, not just the language barrier, but sometimes the information barrier. What I mean by that is, sometimes we try to explain in so much details about certain things, and our patient look more confused than ever.
Yeah.
And then they were like, look, hold on, the doctor is trying to explain to me, I don't quite understand. I don't know what to make of it, So that's another thing as well. And I think I got a question here about from a faith perspective. I think to those or the views from us as a Muslim, we're very, very clear. I think I think most of us ever heard about the hadith of Prophet Muhammad SAW, where he was asked about the Bedouin who left his camel and didn't tie his camel. And the Prophet said, why don't you tie the camel? And he said, look, I put my trust in God. And the Prophet said, well, look, you got to tie the camel first, then you put trust in God. So, and I think that's very important. That's the message to our Muslim viewers, from our perspective, that we do have to put an effort. Without an effort, you can't just say, I put trust in something without actually doing something. That's very important. That's what our faith taught us, yes.
And I mean, I had a case of a patient who happened to be Christian, but the same principles apply, whose child had an episode of rheumatic fever, and we wanted to give regular penicillin injections to prevent the child from ever getting the rheumatic fever again. And the mother said that she was trusting, she had put her faith in God. I put to her that maybe I was God's instrument. and that, you know, how do you know what God's intent is, and what is the right thing to do? And that you need to weigh those things up. And so in terms of that particular child, the risks of not treating were high. And yeah, I think the faith in God is really important, because I've got no doubt that a faith and a belief has all sorts of other health benefits, but I think it's a matter of working how they work together. I love that story. That's great.
And I think that's another thing as well. Being as a doctor, as a GP, you mentioned that before. Even our patient who disagree with the vaccine, or if they're very strong in their faith, if anyone who doctors who are watching this, you need to do not just easily brush off your patients, or just kind of say like, look, I don't believe what you believe, so I can't really give an advice, but really listen to them and have a good discussion. And I'm sure you will have many experiences where people who are certain they don't want to get the vaccine, and later on, 3 months later, they come back and they're happy to have vaccine for their children. And I have that a few in my career.
Yep.
I'm sure you have a lot more than I do. So, and I think it's very, very important to respect differences in opinion, and then have a good discussion. Try to understand where they're coming from, and I think let's talk a little bit about. I think we discussed a little bit in the background before, Dr. Gray, about a lot of people who don't want to immunize or choose not to immunize for whatever reason tend to be more emotional argument, because something has happened.
Yep.
And I think it's a nature of a human being. When something happened, we wanted to put a reason for why this happened.
Yep.
And then when someone out there said, look, a vaccine caused this, and therefore this must be it. Do you want to...
So I mean, the example that we were talking about was that after this connection of MMR vaccine with autism, and that information spread quite widely amongst the Somali community in Wellington, and I was faced with a Somali mother who already had an autistic child who had a new baby, and I was wanting to immunize, and she was saying, I'm worried that if we do that, my baby will become autistic. And look, I get it. I mean, I can't. And part of why I was explaining all the science before is the science cannot be certain. All I can say is they have done really good studies, and we're as sure as we can be, but we can never be 100% certain. And so there are two things that could have happened for that baby. One is that I might have immunized, and it might have caused autism. I don't think that's likely, but from what we know, but that's possible. But it's equally possible that the baby might have going to developed autism, and if I'd given the vaccine just before the baby developed autism, mum would have been even more sure that it was caused by the vaccine. So you need to take that sort of stuff into account. One of the things about vaccination and sick children is that we don't like to immunize children when they're unwell. Part of the reason for that is not because the vaccination won't work, but because if the child gets sicker, the mother will blame the vaccine and then may not want to do the rest of the vaccinations.
Yep.
So those are the things. And look, it's people make their decisions about what's safe and what's not safe on their own experience. So there are people who cross the road without the little green man, They haven't been run over yet. But it doesn't mean the little green man isn't a good idea, So it's a matter of being with people's experience and understanding them and continuing the conversation.
Good. All right. I think that's pretty much it. I think we cover most of it, and I think we kind of indirectly also acknowledge about to those who are hesitant about having vaccine. That's okay. You can think about it. You can wait for a little bit longer until MedSafe or until IMEC, or MedSafe and IMEC is the New Zealand organizations here, to look into the data and came out with before you decide to vaccine. But I'm aware that I think, if I'm right, correct me if I'm wrong, I think the the first group of people who get the vaccine are those who are working on the at the border, I believe, in New Zealand.
That's the
That,
plan.
that's the
Yep.
plan, right?
Yep.
Yeah. Okay.
Yep. So I think in terms of that hesitancy thing, let's be clear. I'm hesitant today.
Mm-hmm.
If I was in England, well, in fact, actually, one of my daughter's school friends is working as a nurse in intensive care units in England,
Right.
and they were rolling out the vaccine in England urgently, and her partner's an anaesthetist, and they weren't sure whether they wanted that vaccine at that time because they weren't sure they trusted the government to have looked at the data properly and that it was safe enough. And so they were happier actually doing a very good job with the PPE, and both of them had successfully avoided infection despite caring for a lot of COVID patients. And I think this is the other thing, is the vaccination. It's one of the tools we have available for managing the problem. It's not the only tool. You know, we're doing perfectly well without a vaccine at the moment. When we get a vaccine, we'll still need all those other tools until such time as COVID is no longer a problem around the world, because unless we get, you know, a large proportion of the population vaccinated and or it stops circulating around the world, we're still going to be at risk of having an outbreak in New Zealand. So we'll still need all those tools. So I think it's a matter of looking at the vaccine as being, it's another tool to be used. And I'm sure that those who are working in managed isolation, you know, their idea about whether to be hesitant or not are going to be quite different from mine, because at the moment they are having to be tested every week. They're being shunned by family and friends who really don't want to go round to their place, sort of appropriately. It's a tough job to be doing. And the thing is that if they were to get the vaccine, it then means that the job becomes less tough to do and they'll be able to keep doing it. So I think the decision will be different from all of us. And I think as time goes on, it'll be clearer that actually the vaccines are effective and safe and exactly what they might achieve.
Now, Dr. Gray, I think before we end the conversation today, there's one question here that someone asking here about, you know, we talk about herd immunity, for example, you know, with MMR, you know, so when a population being vaccinated, if up to a certain level, then majority of the time, you know, we will cover the others as well.
Yeah.
So I haven't come across, maybe I haven't looked hard enough, but are you aware much about in terms of the COVID vaccine, in terms of the herd immunity once being vaccinated, how many population and you know, what the percentage, if you're aware of that?
Yeah. That's the sort of information that it's really hard for us to know without it happening, you know. So I think what we know is that no one's reached herd immunity yet because it's still transmitting widely in all the countries around the world. So we can be sure that a herd immunity of 10% is not enough. So we know that.
Yes.
And then as we go up, you know, and that's why, you know, one of the benefits that New Zealand has of being a very small country is that we can keep really good data on the whole population. And so we will know, and we know, for example, what our herd immunity is for measles. And we knew that it was down too low, and that's why we had an outbreak, and we had to work to get it higher up. So, and the thing about herd immunity is that we will never immunize the whole population, because there's a group of the population who are immune suppressed, who've got other medical conditions which mean that they're unable to be vaccinated, who had an allergic reaction to a previous vaccine possibly. There are a whole range of reasons why there are a group of people who we should never vaccinate. And then there may well be people like my Somali mother who just don't want another vaccine, and they're never going to do it. And, you know, we can understand why, and forcing them to do it's a really bad idea. And so we will be dependent upon trying to get as many people as possible up, because if we get to a high enough number, then actually it will stop circulating in the community, and it will no longer need to worry about the border controls.
Good. I think that's covered mostly. I think I haven't got anything more discussion about it. And I said, look, I think we should end it. And then I think if we got more questions coming through from our viewers, or from anyone else's who, I'm sure there'll be more to come when vaccine was about to be rolled out. So inshallah,
Yep.
we'll get you again, Dr. Gray, and
Yep. That'll be fine.
hopefully Professor Helen, can come as well. So we'll see who's ever available. So thank you so much for coming in. Thank you so much for having a good discussion. I think if you have any thing to say, Dr. Gray, you want to add anything more before we end?
I think this is a great initiative, and thank you for setting it up. And I'm very happy to be available for any future episodes you might have if what I've done is useful.
Oh, definitely. Look, I look forward to see you in Wellington the following weekend, and hopefully we'll catch up then. Hopefully you can give me a feedback about my university feedback. Okay.
Absolutely. Okay.
No worries. All right. Thank you, everyone. To those who watch, we'll end now. And if you have any questions, if you have any more question, either from Islamic perspective or from a medical perspective, please send me an email. Please put a comment here, and then we'll have a discussion a bit more later. And we'll try to do a few more shows on this topic if there is any more interest in that, inshallah. Okay, everyone. Assalamu alaikum, and thank you for watching.
Bye-bye.
And thank you.